Hello, everyone. Thank you, everyone, for joining us for the Yale Department of Radiology Grand Rounds today. I am delighted to introduce Dr. Heiki Daldrup-Link from Stanford University. Dr. Daldrup-Link trained at the University of Münster and the Technical University of Munich, Germany. She is the director of Pediatric Molecular Imaging, co-director of Cancer Imaging and Early Detection Program, and Associate Chair for Diversity for the Department of Radiology at Stanford School of Medicine. Dr. Daldrup-Link's research interests focus on development of novel pediatric molecular imaging techniques and multimodality imaging technologies with expertise in PET MRI. She is the principal investigator on multiple active NIH-funded R01 and R21 grants, with one of the grants being an R01 on personalized whole body staging for children with cancer. Thank you, Dr. Daldrup-Link, for sharing your expertise with us.
Thank you so much for the kind invitation and for the kind introduction, Mariam. It's a great honor and so it's via Zoom. And so welcome everybody online, and I will start sharing my screen. Our group has been working on PET MRI of children with cancer for the last several years. And in fact, in our clinical routine, we have replaced PET-CTs by PET MRs for pretty much all of our pediatric oncology patients. And so today I will share some of these insights, both from our clinical practice and also from our research enterprise. So the topic is whole body PET MR imaging of children with cancer. Before we start, a few acknowledgements. I do have a few patents related to nanoparticle imaging, and I would also like to acknowledge my grant support from the NIH and from several foundations. And our entire team is very grateful for this support. So I would like to start with the big picture, and I think this is nicely summarized in one of my favorite quotes from Albert Einstein, who once said, if I had an hour to solve a problem, I'd spend 55 minutes thinking about the problem and 5 minutes thinking about the solutions. Well, I'm not Albert Einstein, so I need a little longer to find a solution, but I do agree and have learned over the years that it is really worthwhile to think carefully about the problem that we are trying to solve. And so with this in mind, I think the following slides show the big picture and the main problem and question that we are trying to address with whole body cancer staging for pediatric patients. When a child with a newly diagnosed cancer comes to us for their imaging diagnosis, then this child often has to undergo a multitude of imaging tests: an X-ray, an ultrasound, a CT or PET-CT, an MR, a bone scan, a biopsy. Then therapy is initiated. And after some time, this cascade of imaging studies is started over again. Wouldn't it be so much better if all the questions that our oncologists have for us could be answered with just one imaging scan? So the patient would just come once to us for this one comprehensive imaging diagnosis. And that is what we are trying to achieve with these whole body cancer imaging studies. So with my talk, I will first discuss diffusion-weighted whole body MRI and where we are still using whole body MRI as opposed to integrated PET MR. Then I will talk about integrated PET MR, both how we do it, and I will show you some cases. And finally, I will talk about artificial intelligence algorithm as we found them useful for whole body cancer staging. So I will start with diffusion-weighted MRI. So to bring us all on the same page, here I want to show the basic principle. As most of you may know, diffusion-weighted imaging is based on the Brownian motion of water protons in the body. And in normal organs, these water protons can move around freely. And so if we send a spatially encoded radio frequency pulse into a voxel of a normal organ, and then we wait some time, and then we detect signal that comes back from these excited protons, then we get very little signal back because these protons have meanwhile moved elsewhere. So normal organs usually provide very little signal on diffusion-weighted images. In tumors, there's typically a higher cell density than in most normal organs, and therefore the protons cannot move around as much. And therefore, when I send a spatially encoded radio frequency pulse into a voxel that covers the tumor and wait some time, and then I detect signal that comes back from the excited protons, now I do get a strong signal back because the protons couldn't move as much. And what I get is shown as an example here in a patient with Hodgkin's lymphoma, where you see a big mediastinal mass and multiple mediastinal lymph nodes in this patient, which show restricted diffusion, and these tumor nodules appear bright on these diffusion-weighted images. So our team has taken this approach. We acquired whole body diffusion-weighted images. Here you see a metastasis from a soft tissue sarcoma in the lower pelvis. We have then inverted these images, color encoded them, and superimposed them on contrast-enhanced T1-weighted gradient echo images. And with that, we get integrated color-encoded images which look like a PET-MR scan, but they are actually diffusion-weighted images, color-encoded and superimposed on a contrast-enhanced MRI. And these images are completely radiation-free and can be acquired with any MRI machine. So some time ago, we did a study where we compared the sensitivity and specificity of these integrated diffusion-weighted MRI scans with PET-CT scans with regards to the detection of pediatric tumors at baseline before therapy. And we found similar sensitivities, specificities, and diagnostic accuracies for the two imaging technologies. So our pediatric nuclear medicine physicians, of course, brought up the critique that we do not only need to detect tumors, we also need to monitor their response to therapy. So we subsequently conducted a study where we evaluated the respective performance of PET-MR and diffusion-weighted MRI for treatment monitoring of different pediatric tumors. Here you see an example of a patient with Langerhans cell histiocytosis with a lesion in the right iliac wing of the pelvis. You see this lesion is metabolically active at baseline on the FDG PET scan, and you can also see it here on the integrated PET-MR scan. And here you see this lesion also shows some restricted diffusion, and we can see it on the integrated diffusion-weighted MRI scan. And here is a follow-up scan after chemotherapy. You see the lesion shows some partial response on the PET scan and also on the diffusion-weighted scan. So for patients with Langerhans cell histiocytosis, we checked whether we can determine tumor response or non-response based on classic changes in tumor size at the end of therapy. Whether we could predict tumor response on an early interim scan, either with the PET or with the diffusion-weighted scan. And we found that the responders, as expected, showed a decreased tumor SUV value. The non-responders did not. And similarly, the responders showed an increase in tumor ADC value, whereas the non-responders did not. So we felt that in certain cases of Langerhans cell histiocytosis, we can provide tumor detection and treatment monitoring with MRI and diffusion-weighted MRI only. We also looked at patients with lymphomas and sarcomas. Here you see an integrated diffusion-weighted MRI of a patient with Hodgkin lymphoma and a mediastinal mass. Here you see the PET-MRI with the hypermetabolic mediastinal mass. And this here is after induction chemotherapy. And you see that in both instances, we can see a complete response of this tumor. So we looked at the ability of FDG PET-MR and whole body diffusion weighted MRI to determine therapy response based on classical criteria, and looked at the agreement of these two imaging techniques. For patients with sarcomas, we found a relatively high agreement with an alpha value of 0.94. For patients with lymphomas, we found a much lower agreement. And we looked in more detail why we had this lower agreement. And here you see a classical example of what we found in these patients. This here is a patient with a malignant lymphoma in the right inguinal region. And you see this lesion is highly metabolically active on the PET scan, PET-MR scan. And you also see that this lesion shows restricted diffusion on the integrated diffusion weighted MRI scan. So now after induction chemotherapy, we see a complete metabolic response on the interim scan, on the interim PET scan, and we see still some restricted diffusion in this area on the diffusion weighted scan. Then at the end of therapy, we see a complete response on both imaging techniques. And so what we found is that actually the metabolic response apparently occurs earlier compared to the response that we see on diffusion weighted imaging. At baseline, tumors have a high metabolic activity and also show restricted diffusion. Then after chemotherapy, the metabolic activity decreases. However, we have still a high cell density in the tumor tissue. Subsequently, tumor cells die, and this leads to an increased interstitium and now increased diffusion of the protons. So we see the response, the metabolic response typically earlier compared to the response on diffusion weighted scans. And that's why we think that for certain tumors, such as lymphomas, we have not identical information, complementary information on the PET scan and the diffusion weighted scan, and therefore their combination may be useful for our patients. So next I want to talk about the PET-MRI imaging technique. Here you see our PET-MR scanner under maintenance, and this is actually a 3 Tesla wide bore MRI scanner in which there is an introduction of a PET detector ring. So the PET detector ring has been introduced into the inner bore of a wide bore 3T MRI scanner. Then the actual bore size when the patient enters the scanner is similar to a standard 3T MRI scanner with a bore like a diameter of about 60 centimeters. Here you see our research PET-MR scanner in action. This is actually the son of one of our administrative assistants who kindly posed as a patient. And this here is Dr. Anne Mühe, one of our research associates. We initially measured the radiation exposure that our patients encounter when they undergo a PET-CT scan with a fully diagnostic contrast-enhanced CT as required typically for our lymphoma patients, as opposed to the PET-MR. And since we have more sensitive PET detectors in the PET-MR scanner, and we have longer PET data acquisition times per PET bed, we can actually inject a lower radiation radio tracer dose than needed for the PET-CT. And therefore, by exchanging the CT with the MR and injecting somewhat lower radio tracer doses, we inject 3 megabecquerel per kilogram, we could reduce the radiation exposure of our patients by almost 80%. Here you see the PET-MR scanner in our children's hospital. And as I mentioned, we have pretty much replaced all PET-CT scans in our pediatric patients with PET-MR scans now. Here you see our workflow. Our patients are first screened and prepared for the scan. We inject FDG. Then we let the patients wait for about 40 to 45 minutes. Then we place them on the scanner, and we have to place the different coils for a whole body scan. So that takes a little bit of time. And so by the time we start the actual scan, we have an uptake time of about 60 minutes. Then we plan our PET-MR whole body scan. And we usually first plan the PET beds because we think that this is our time limiting step. We cannot go faster than the time needed to acquire our PET data. Initially, we started with 4 minutes. Now we are down to 3 minutes per PET bed. And then we place as many MRI sequences as is possible within the available time window for this PET data acquisition. And so in our case, we add diffusion-weighted images, we add T1-weighted contrast-enhanced gradient echo images, and then a 2-point Dixon sequence for attenuation correction of the PET data. For patients where we also need a scan of the local tumor, we typically add that in the end. For example, for a sarcoma, we add dedicated sequences through the primary tumor. So typically for the whole body scan, we need about 20 to 30 minutes, depending on the length of the patient. And then we have another 20 to 30 minutes for the primary tumor. And with that, our whole scan can be done within 60 minutes or less. Here you see the pulse sequence parameters that we apply for our scanners. And for anybody interested in more details, you are welcome to contact me about the specifics of this technique. So here's an example of our integrated PET-MRI scan. As I mentioned, we acquire the PET and the contrast-enhanced MRI data simultaneously. This here is the fused scan. And this patient here had a high tumor burden. You see multiple positive lymph nodes here, and then extensive peritoneal metastases. This was a patient with a desmoplastic small round cell tumor. And so in this case, we were also interested in adding more detailed sequences through the pelvis so that we could have a closer look at the primary tumor in the pelvis. We then take these data and perform coronal and sometimes sagittal reconstructions. And here you see such an example of a coronal reconstruction, and you can appreciate the marked tumor burden of this patient with extensive peritoneal metastases and then also multiple lymph node metastases and also bone lesions. We perform some images with gadolinium-enhanced scans, and I personally study the use of ferromoxitol iron oxide nanoparticles for whole body imaging applications. Ferromoxitol is an FDA-approved iron supplement, which we use off-label as a contrast agent for MRI. Ferromoxitol is composed of iron oxide nanoparticles with an iron oxide core and a carboxymethyldextran coat. And these nanoparticles have a high R1 and R2 relaxivity. That means they provide positive contrast on T1 weighted images and negative contrast on T2 weighted images. So when we inject these nanoparticles intravenously, then initially they distribute in the blood pool because the nanoparticles are relatively large with a diameter of about 20 to 30 nanometers. So they do not quickly extravasate and therefore provide a very long-lasting vascular enhancement over several hours. And this can be used for vascular imaging. As you can see here, you see the mediastinal vessels opacified and also vessels in the pelvis. And here you see another example of a whole body scan of a patient with lymphoma. And you can appreciate the hypermetabolic mediastinal mass here, and you can very well delineate it from the mediastinal vessels. You also can appreciate a small lesion in the spleen here. Here is another example of a patient with an osteosarcoma of the right proximal humerus. So initially we perform a whole body scan. Since the patient is already in the whole body coil, we can easily acquire a scan from joint to joint, which helps us to determine the local tumor extent and also to check for skip lesions. You can appreciate the beautiful vascular enhancements that we get with the nanoparticles here, and which shows the vascular supply and vascular drainage of this tumor, which is very important for surgical planning. And then after the whole body scan, we apply a local surface coil to look in more detail at the primary tumor. And in this case, you see that this tumor actually infiltrated the joint, which again is very important for treatment planning. Here you see another patient with an osteosarcoma of the proximal tibia. You see this lesion has a very large soft tissue component. And again, you can appreciate the strong vascular enhancement with ferromoxitol nanoparticles. And this allowed us to detect a tumor thrombus in the popliteal vein. And that again is very important for the surgeon to know, because as you might know, for osteosarcomas, it's important to resect the entire tumor, including any tumor thrombosis. So next, the iron oxide nanoparticles slowly leak through sinus in the reticuloendothelial system. And here they are phagocytosed by macrophages in liver, spleen, lymph nodes, and the bone marrow. And this causes a negative or dark signal effect on T2 weighted scans. Here you see an example of an axial scan through the abdomen before and after iron oxide injection. And you see that the normal liver tissue shows a darkening effect after iron oxide administration. And focal metastases in the liver do not take up the iron oxides in this relatively early post-contrast period, and therefore can be better detected. Here you see examples how this can help. This here is a patient with an HCC on a pre-contrast T2 weighted scan, and post-contrast T2 weighted scan. You see the normal liver parenchyma shows a darkening effect, and we can now better delineate the tumor and also a small satellite lesion here. On the T1 contrast enhanced image, you see a gadolinium enhanced image here, and by comparison, the iron oxide enhanced image, you can appreciate how well we can delineate the vessels from the tumor on this iron oxide enhanced scan. I want to show you a few more case examples. Here you see another patient with a desmoplastic small round cell tumor, extensive peritoneal metastasis on this pre-contrast T2 weighted scan. Here you see a gadolinium enhanced scan from a whole body imaging exam. And here you see the corresponding iron oxide enhanced scans. On the T2 weighted scans, we get a darkening effect of the normal liver tissue, and that helps us to better delineate the peritoneal metastases and lesions in the liver here. And on the T1 weighted scan, you can very well delineate the vessels from these tumor deposits. And then here is the simultaneously acquired PET scan, and you can see the perfect co-localization of the PET information with the MRI images due to the simultaneous PET data acquisition. Here is another example of a patient with a gastrointestinal stromal tumor at the posterior wall of the stomach here. Unenhanced T2 weighted scan, gadolinium enhanced scan. On the T2 weighted scan, you might notice that there are several lesions in the liver here. And here is the iron oxide enhanced scan. And on the T1 weighted scan, you can appreciate how much better we can delineate the primary tumor from the splenic vessels. And on the T2 weighted scan, you can appreciate how much better we can delineate multiple metastases in the liver here in this patient. And here you see the co-localization of the simultaneously acquired PET information. And again, you can now see that these lesions are in fact hypermetabolic and are confirmed metastases. So we did a quantitative analysis where we measured the tumor to liver contrast, tumor to vascular contrast, and tumor to marrow contrast, and compared this value for gadolinium-enhanced MRI images and ferromoxitol-enhanced images. And for all of these, we found a better contrast for our ferromoxitol-enhanced scans. Here is another example that shows that we can apply the same principle also to the detection of lesions in the bone marrow. Here you see a T1-weighted sagittal scan and a STIR scan of a patient with lymphoma and suspected focal lesions. And here you see the iron oxide enhanced scan. Again, the normal bone marrow takes up the iron oxides, and with that we can delineate focal lesions better. And this patient had multiple lesions. Here you see another example of a patient with a soft tissue sarcoma and multiple metastases in the bone marrow on the iron oxide enhanced scan, and then also on the integrated PET-MR scan. The same principle also applies to primary tumors. Here you see an osteosarcoma of the right iliac wing, unenhanced T2-weighted scan and ferromoxitol-enhanced T2-weighted scan, and you can better delineate the border between the tumor and the normal ferromoxitol-enhancing bone marrow on this ferromoxitol-enhanced scan. And this border is also confirmed here by the simultaneously acquired PET scan. Here's another example how the FDG PET information can be helpful in these patients. This is another patient with an osteosarcoma, initial whole body scan. We didn't see additional distant metastases. And here you see the local scan. You see the coronal T1-weighted MRI image and the superimposed PET image, and you can see that this is a highly metabolically active tumor. Here you see the post-treatment scan, and you can appreciate that there is a metabolic response of this tumor on this interim scan, while the tumor didn't shrink much yet on the anatomical scan. So in this case, the metabolic information is really helpful to tell us that this tumor responded to chemotherapy. Here is the opposite example. This was a patient with a Ewing sarcoma of the left scapula. And also here it is interesting, the patient was first entered the scanner, we started the scan, and then the patient had to go to the bathroom. So with our ferromoxitol nanoparticles, that's no problem at all. We have a vascular enhancement for hours. So the patient can leave the scanner, can come back, and we have the same beautiful vascular enhancement. So here you see the whole body PET scan, and you can appreciate that there is a marked metabolic activity of the left scapula. Here you see the anatomical scan. There's a large tumor in the left scapula, which turned out to be a Ewing sarcoma. This tumor shows a sort of ring-like FDG uptake with a central photopenic area, which is a prognostic unfavorable sign. And in fact, this patient came back after induction chemotherapy. For Ewing sarcomas, usually we expect that the soft tissue component of the tumor shrinks significantly after chemotherapy, but in this case, it did not. And in fact, you see that this tumor shows an increased metabolic activity on this interim scan, and also a new lesion in the scapula. So here we actually consulted several reference centers what to do in this patient. And it was decided to move on with local control. So this tumor was resected. But unfortunately, several months later, the patient came back with widespread metastatic disease. So at this point, the primary tumor was resected, but the patient had new lymph node metastases, as you can also see here. new pulmonary metastases, and multiple bone lesions. And you can appreciate that we can very well detect all of these lesions with this one-stop imaging scan. And that was very helpful because at this point, the patient was very sick. The iron oxide enhancement can be helpful in cases where we see reconverted hematopoietic marrow. Here you see a patient who received chemotherapy and therapy with granulocyte colony stimulating factor, which leads to a very hypermetabolically active bone marrow on the PET scan. The patient also received ferromoxitol, and you see that the entire bone marrow shows a darkening effect on T2 weighted images, which shows that this is all normal bone marrow. There are no focal lesions here. Here's the opposite example. This here was a patient with a metastasis in the right iliac wing from a soft tissue sarcoma. You see this lesion is positive on the PET scan and also shows up on the integrated PET MRI scan. This patient underwent chemotherapy and also showed reconverted hematopoietic marrow on the interim scan. And this made it difficult to delineate the tumor here. Here again, you see the integrated PET-MR scan. So it was difficult to determine the response status based on these images. The patient also got his ferromoxitol enhanced T2 FET-SET MRI simultaneously acquired. And you can see the original lesion here in the right iliac wing. And you see that after therapy, this tumor actually grew, which we would probably not have noticed when we had looked at the PET scan or PET CT scan only. So this was really important to recognize that this tumor grew under therapy, and this patient got some local radiation to this tumor. So we looked at bone metastases in our patients and actually looked at a total of more than 200 bone marrow metastases on the PET part of the PET MRI and on diffusion weighted images. And we actually noticed that we did not detect or miss some metastases on the PET scan. These were typically very small metastases and metastases in these instances where we had highly metabolically active reconverted marrow. The diffusion weighted MRI also missed some metastases, and these were typically metastases in certain bones which we know are difficult to evaluate with MRI, such as the bones of the lower arms and hands and feet, and the bones, the rib cage, the ribs. And so when we took these two imaging technologies together, then we actually got 100% sensitivity and specificity. So we do believe that the integrated PET-MR technique is particularly useful for cases where it's very crucial to detect bone metastases and all bone metastases that a patient has. So we recently published an international expert opinion statement on this topic, and you can read more on this for both pediatric and adult patients in this publication that you see here. We also looked closely at the performance of PET-MR for the detection of pulmonary nodules, and we did that with regards to the size of the pulmonary nodules. We started with CT. In this case, this was a CT of the PET CT, and we compared a PET-MR obtained in the same patients. And you see a 1 centimeter pulmonary nodule here, which we see on the CT, the PET, and also on the MRI. For the chest, we acquire propeller sequences which suppress cardiac motion. And so we get very limited artifacts on these sequences, and we found those most useful for the detection of pulmonary nodules. So we feel very confident in detecting pulmonary lesions that are 1 centimeter in size or larger. Here you see another case of a 6 millimeter lesion. We did see it on the CT, on the PET of the PET-MR, and also on the propeller sequence. You might also notice a lymph node in the mediastinum in this patient. Here is a 5 millimeter lesion, and this is where we get to the limitations of the PET-MR. You clearly see it on the CT. You also actually see it on the PET of the PET-MR, but it gets really difficult to detect it on the propeller MRI due to surrounding susceptibility artifacts. So here we counted pulmonary nodules in our patients, and when we looked at the combined PET-MR scans, we found 94% of pulmonary nodules that were more than 5 millimeter in size. However, we missed 80% of pulmonary nodules that were smaller than 5 millimeter. So we clearly have to improve this technique for the detection of pulmonary nodules that are 3 or 4 millimeter in size. We looked back at the reason why we missed these lesions. And actually, when we look at the in-plane resolution of our MRI images, we should have an in-plane resolution that should allow us to detect 3 or 4 millimeter pulmonary nodules. The in-plane resolution of the MRI is slightly lower compared to the CT of the PET-CT. And when we looked at very small pulmonary nodules on the CT and put our propeller MRI side by side, we could actually see these lesions. However, the problem was that we had a lot of other artifacts on our images, which made it impossible to distinguish these true tiny pulmonary nodules from some other artifacts. And I think this is because on the CT, we can follow vessels similar to a branching tree, whereas we cannot do that on the MRI. And therefore, there's some confusion with these small nodules. So I think to solve this problem, I think we already have the local anatomical resolution, but we would have to solve this vessel problem, either by better showing the branching vessels just as we see it on the CT, or by completely suppressing the vessel signal. So next, I want to talk about how we integrate artificial intelligence algorithms in these investigations. And again, I want to start with an overview that was kindly provided to me by my colleague Kurt Langlotz and Matt Langren from the Stanford Amy Center. So Kurt Langlotz's definition of artificial intelligence is that artificial intelligence is anything that a computer does that makes humans seem intelligent. Machine learning is rapid automatic construction of algorithms from data, and neural networks are a subset of machine learning algorithms that represent a powerful form of machine learning. And deep learning algorithms represent neural networks with many layers. So here you see different evolutions of artificial intelligence algorithms. In the 1950s, actually, initial computer algorithms were developed that allowed a differentiation of benign and malignant lesions based on certain rules, such as a certain characteristic, a certain SUV value, a certain matrix that we could acquire that could potentially differentiate benign from malignant tumors. Next, machine learning algorithms have been introduced, which were able to extract several different features of tumors and therefore provide a more sophisticated differentiation of benign and malignant lesions. And more recently, neural networks and deep learning algorithms have been introduced, which can interrogate a multitude of characteristics of benign and malignant tumors and learn in the process of being fed with different benign and malignant cases such that we get an even better discrimination of the two. So my colleague, Kristen Yeom, has used this approach to differentiate medulloblastomas based on their radiomic signatures. And she was able to differentiate 4 different tumor types based on artificial intelligence algorithms and different features. And this was important because different histopathologic subtypes of these tumors have vastly different prognosis. Our group used artificial intelligence algorithms to augment ultra-low PET data. So we wanted to develop algorithms that would allow us to take an ultra-low dose PET scan and augment it into a standard dose PET scan. And that would allow us to further save radiation exposure for our patients. Such an algorithm could potentially be also used to speed up the exam by taking low resolution scans and augmenting them into high resolution scans. We recently published a study on this research and have several others underway. So in this particular study, our collaborating computer scientists developed an algorithm that inputs ultra-low dose PET data. We could go down to 6% of the original dose, and also inputs simultaneously acquired PET data, and now the simultaneously acquired MRI data. And now the MRI data are used to generate the anatomical information for a corresponding integrated scan. And the PET information is used to determine the intensity of the FDG uptake in a certain target organ. And that gave us an output of an artificial intelligence reconstructed full dose PET scan. In addition, our computer scientists also trained the AI algorithm to pay attention to certain areas where we typically find tumors, and that is particularly in our cases of mostly lymphomas and sarcomas, the perivascular areas. So the algorithm paid particular attention in accurate reconstruction of the perivascular areas where we often find tumors and metastases. Here you see the result. This here is the original MRI scan of a patient with Hodgkin's lymphoma. You see multiple mediastinal lymph nodes here. You also see a lymph node at the lower neck. This here is a standard dose PET scan, and you see multiple hypermetabolic lymph nodes in these same areas. This here is a simulated 6.25% ultra-low dose PET scan. So we took the list mode data of these patients and took only 6.25% of the data and reconstructed and simulated ultra-low dose scan based on this. And this would be equivalent to a radiation exposure of about 0.1 to 0.2 millisievert. Very, very low radiation exposure. And then we applied the artificial intelligence algorithm that I just showed you to reconstruct standard dose images. We then asked 4 readers, 2 radiologists and 2 nuclear medicine scientists, 2 nuclear medicine physicians, to review these imaging scans and determine for different areas of the body whether there was tumor in these areas or not. And we determined the agreement of the original ultra-low dose scans with the standard dose scan and the AI reconstructed PET scan with the standard dose scan as a standard of reference. And we found a very low correlation or agreement between the ultra-low dose scan and the original scan, but a high agreement for the AI reconstructed scan. We also found that the SUV values of normal organs, liver, mediastinal blood pool, and also the tumor, were abnormally high on our ultra-low dose scans. And that is because the increased image noise leads to artificially increased SUV values when we measure those organs. And the AI reconstructed PET could recover this information. So on the AI reconstructed PET, we measured SUV values that were not significantly different to the 100% standard dose scan. More recently, we performed another study with a commercially available AI algorithm, because what I showed you before is our personal AI algorithm at Stanford. So how could that be useful to your group, for example? And so we recently studied a commercially available AI algorithm and did similar studies where we compared the performance of the AI reconstructed PET scans with regards to the standard dose scans. And you see, we got a very great, a nearly perfect agreement for 75% dose reduced scans, for 50% dose reduced scans, and almost perfect agreement for 25 dose reduced scans. But then for lower reduced scans, we got a marked deviation and quite some errors. So we think that we can easily reduce our radio tracer dose by about 50%. So in the future, we would want to integrate additional information into artificial intelligence algorithm for improved tumor diagnosis. And this would include these biological variables that you see here. And we started working with our oncologists on the integration of circulating tumor DNA. Here you see two cases. This here is a patient with a rhabdomyosarcoma who underwent radiation therapy and chemotherapy, and we measured the size of the tumor. These are the black lines and black dots here. And we also measured the circulating tumor DNA. And you see that in this particular patient, the size of the tumor and the circulating tumor DNA both decreased in response to the treatment of the patient. Here is another patient with a Ewing sarcoma, where we also looked at the tumor size and at the circulating tumor DNA. And in this patient, we actually saw a decrease in the circulating tumor DNA before we saw a significant decrease in tumor size. And so we think that the integration of such blood biomarkers may help us to detect a response of tumors early after start of chemotherapy. So artificial intelligence algorithms can have many other applications, as shown here. We can determine the positivity rate among similar patients. As I showed you, we can lower radiation dose and imaging time. We can reduce patient callbacks. We can decrease the length of stay by AI-derived image triage. We can prevent or detect diseases early among different populations through computer-aided detection. We can also provide disease classifications by selecting precise treatment for each patient. And we can also provide intelligence image reports by communicating critical data more timely through a learning health system. So with that, I'm at the end of my talk. I showed you how we can use whole body imaging techniques for children with cancer. Currently, we still use whole body MRI and diffusion weighted MRI for patients with cancer predisposition syndromes and for patients with Langerhans cell histiocytosis. We use integrated PET MRI techniques as a one-stop local and whole body staging technique for mostly patients with lymphomas and sarcomas, among some others. And we are still working on the detection of pulmonary metastases, which needs some improvement for the detection of very small and tiny pulmonary nodules. And we are integrating artificial intelligence algorithms to reduce the radiation exposure of our patients, to speed up scans, and to provide automatic tumor staging and response assessments. I would like to thank our team at Stanford for their contributions to this work, and I thank you for your attention.
Thank you, Dr. Daldrup-Link. This was a fantastic presentation. We're about to start on the Q&A portion of the discussion. And let's see. So far, have there been, does anyone have any questions? Let's see, Dr. Saperstein says, great talk, powerful techniques. It seems that the PET-MR scans take much longer than the PET-CT scans. How do you address patient comfort and workflow challenges?
Mm-hmm. Yeah, this is a very good point. Thank you for bringing this up. I must say our first patient stayed for more than 2 hours in the scanner, which was, of course, totally unacceptable. And especially for our pediatric patients, you know, image quality degrades rapidly over time. So for us, it is particularly crucial to provide time-sensitive scans. And so at the beginning, when we started this, we actually had a research associate who had a stopwatch and stopped every single part of the exam. And with that, we came up with our most streamlined protocol. So now the protocol that I showed you in my talk takes about 1 hour. And we feel that most of our patients can comfortably do this. As I mentioned, we sometimes do have the problem when we do a whole body scan and then we add a local scan. That requires to take the patient out of the scanner and then apply a local coil. So patients are usually relieved, oh, this is it, and they are ready to leave the scanner or at least go to the bathroom. And so we solved this problem by administering the iron oxide nanoparticles. So with that, we can take a break if that is needed, and then have beautiful vascular contrast throughout the entire scan. But like coming up with a protocol that is streamlined is really crucial for these patients. Mm-hmm.
Thank you so much. We have another question from Dr. Aurora in terms of the methods for billing, of how would you bill for the ferromoxetol, considering
Mm-hmm.
that it's not
common. I don't know the details of the details, but what we typically do is we create 2 accession numbers. One accession number is for the PET exam and one accession number is for the MRI. And I know our billing team worked quite a bit around what the MRI is because there's no CPT code for whole body MR, to my knowledge, I think. And so they worked quite some time around that. If the patient also gets a local scan, then sometimes we have 3 accession numbers. One for the PET, one for the whole body scan, and then one for the local scan. So far, we always review these together. You know, we have Helen Nadell in our department, and she is located in our reading room, our general pediatric reading room. So that makes communication easy. And so we always review these scans together. Nowadays, our neuroradiologists actually have their own reading room. And so if we have the combination of a whole body scan plus a head, then the neuro team has their own accession number and they provide their own separate report. For most of our scans, like if I have a lymphoma patient and there's no, like we as an initial screening don't see anything in the head, then our general radiology team provides a general report. if there's any concern or if there's any increased risk of the patient that there could be metastases in the head, then the neuroradiologist formally reads the head and provides their part of the report. Mm-hmm.
That's great. Thank you. We have another question from Dr. Goodman. He says that it's a very interesting lecture and thank you. Do you still routinely do CT as well as the PET-MR in children?
Yeah, so at this point, almost, so all of our sarcoma patients get a CT of the chest after the whole body MR, because for these patients, it's really crucial to detect the 3 and 4 millimeter nodules. 1 or 2 millimeter nodules, to my knowledge, at least in our patient population, do not have any consequence. So we decided with our oncologists, it's not a goal to detect these 1 or 2 millimeter nodules, but we have to detect the 3 and 4 millimeter nodules. So as long as we cannot reliably do that, we perform a chest CT right after the whole body PET-MR at this point. We are optimistic that we can solve this problem.
That is excellent. And the other question that I have is, do you use a lot of some of the novel tracers for PET imaging in addition to the FDG? And do you make them on site at the cyclotron, or do you bring them from outside?
Oh, that I don't know which tracer comes from where, but yes, this is pretty much also Helen's domain. We do a good amount of DOTATEC exams. So there we have a whole group of patients and got some interesting data. Beyond that, I must say, I do not know. We have, of course, on the research side, we have a whole variety of tracers that we are examining. Corinne Baina from the MIPS team is working on very interesting new tracers for brain tumors, which might be also of interest for your team. But in the clinical routine, I think at least in our pediatric world, DOTATEC is a common one. Of course, our general adult team has a lot of interest in PSMA tracers, and I think André Iagaro has, I think, 3 different tracers for prostate cancer. So the team is very, very active there. And we do have an own cyclotron, but I do not know which radio tracers are produced where.
Oh yes, yeah. It's just the challenges of clinical translation are always different from the research ones, so that's why I was asking. Well, we really appreciate you joining us for the grand rounds. We wish it was in person, and we learned a lot, and we're hoping to take your lessons as we implement our own PET-MR system here.
Yeah, thanks so much for having me. And if you have any questions or if you wanted to collaborate on anything, we would be very happy to do so.
Yes, we're very excited to collaborate.
Okay.